Hi, my name is Jessica Boughton. I'm a VAD coordinator at Abbott Northwestern Hospital. Today I'm going to share a little information with you about how to properly care for an LVAD patient during an emergency. When we take a step back, how do patients become LVAD patients? They are end-stage heart failure patients where the heart can no longer pump enough blood to supply oxygen to meet the demands of the body. Typically, when this happens, the muscle thins out and the ventricle balloons out and it's no longer able to support. We try to treat patients with heart failure by the standard medical therapy options. When that no longer works and we're starting to see frequent flyers back to the hospital needing IV medications as diuretics or sometimes inotrope medications to increase the squeeze of the heart, that's when we start looking at some of the advanced options. Typically, heart transplant is still the gold standard as the treatment of heart failure, but what we know about heart transplant is that there are about 2,000 donor hearts in the U.S. Minnesota typically transplants about 100 patients a year, and so that leaves a lot of other patients needing support. We can use mechanical heart pumps, or LVADs, ventricular assist devices, to help meet the demands that the body needs. The goal of doing this is to improve patients' survival and their quality of life. Typically, end-stage heart failure patients that are deemed inotrope dependent have about a 6-month survival of 50% and a survival of about 20% at a year. When we look at VAD therapy, we can put an LVAD in a patient and get a 80 to 85% chance of survival at a year. We're also looking to improve quality of life with these patients. We use the New York Heart Association class to determine heart failure quality. Typically, end-stage heart failure patients are class 4, where they have symptoms at rest, and our goal is to allow them to be able to do heavy exertion without having any heart failure symptoms. We can put pumps in for people as bridge to transplant. As they're awaiting heart transplant, they may become too sick to wait for a donor, or the wait time is deemed too long. We can put pumps in as destination therapy or long-term therapy, meaning the patient will have these devices for the rest of their life. They are typically patients that are either older, and don't meet the criteria for transplant. We typically don't transplant people over the age of 70, or other comorbidities that allow them to not be transplanted. Patients that are smoking don't qualify for transplant, so they may get a device and spend some time stop smoking. We typically give them about a year, and then we can evaluate them for transplant at that time. We also have a small subset of patients that can go on and have their hearts recover. These are typically young patients. They present with a viral type illness. They don't have enough time to go through standard medical therapy. We can put a pump in and over time treat their heart failure. We can see the heart recover, and we can actually take the pumps out. There are 3 main systems that are on the market right now that we use for ventricular assist devices. We have the HeartMate 2. HeartMate 2 has been around for about 12 years. We still have about half of our patients that have this device, though we're no longer implanting it. It sits in the left chest, just below the diaphragm. The inflow cannula, the silver portion, sits inside the left ventricle. The outflow graft then stretches to the top of the heart, right outside the aortic valve, so we're pulling blood out of the left ventricle through the pump and pumping right outside the aortic valve. The drive line then comes out through the patient's abdomen and it attaches to the external equipment that you're going to see. We have 2 other devices. The Heartware device is a smaller device. It sits into the pericardial space like a button on the apex of the left ventricle. This device also has an outflow graft that reaches up to the aorta and a drive line that comes out to the external equipment that you'll see on the outside of the body. The newest pump that we have available is HeartMate 3. HeartMate 3 again is a centrifugal flow pump. It sits like a button on the apex of the left ventricle, outflow graft up to the top of the aorta, drive line comes out. Right now at Abbott Northwestern, we are solely implanting HeartMate 3s because of the new technology. The way that this pump works is it's magnetically levitated. We no longer have metal touching metal, and we see less thrombus formation with this pump. The way that all 3 of these devices work is they're continuously flowing blood throughout the body. It may be difficult to see, but I have the HeartMate 2 pump running, and in this tubing, that does not go inside the patient, but the tubing here is for demonstration, you can see the blood flow. This is providing about 6 liters of blood flow through this device. When we look at how it flows through the heart, we need the heart to work on the right side normally. So blood's going to flow into the right side of the heart and off to the lungs, back to the left atrium, into the left ventricle, and then it's going to go out to the aorta where it travels to the rest of the body. Because of this continuous blood flow, it's going to affect how you're able to assess your patient. Your patient may or may not have a pulse. The way that the pump works, because it pulls blood out of the left ventricle and it dumps it into the aorta, we no longer have a pressure gradient change and the aortic valve doesn't always open. So you may or may not find a pulse. It'll depend on the type of pump that you have. It'll depend on your patient's volume status. It'll depend on their blood pressure, and it'll depend on the speed of the pump. If you don't have a pulse, how are you going to take blood pressure? It can be very difficult to obtain. You can try to use an automatic cuff to get it, but what we want you to focus on is the mean arterial pressure. What we know about continuous flow is it augments diastolic pressure up and systolic pressure down, so you have a very narrow pulse pressure. It is not uncommon to find VAD patients that have blood pressures of 75/60. It's an adequate mean pressure, and they're going to be doing just fine. We target this mean pressure of 65 to 85. We know that any pressures higher than that make it more challenging for the pump to work effectively. If you're unable to get a cuff pressure, we suggest using a Doppler and a manual cuff. Now we know that most people don't carry Dopplers and manual cuffs, so you may have to go without blood pressure as part of your assessment. Oxygen saturation can also be a challenge for patients that have an LVAD due to this continuous flow. Portable SAT monitors tend to not work very well. You can try using oximetry on the forehead. Sometimes you have better luck, but realistically, we have to look more at what is the patient looking like. Are they warm? Are they pink? Do they look like they're oxygenating okay? Are they mentating? Those are all things that you're going to have to use because you don't have vital signs to assess this patient. EKGs shouldn't be affected by the LVAD because they're working on the electrical system. However, the HeartMate 3 pump is known to create some artifact, and so you have a very junky baseline. It's very difficult to get a 12 lead with a HeartMate 3 pump. Some of the common complications that go along with VADs include bleeding. The most common areas that we see bleeding happening are nosebleed, GI bleeding, and occasionally intracranial bleeding. The statistic with bleeding is about 20 to 25% of patients will have at least one episode of bleeding throughout their time on VAD therapy. You're going to treat bleeding the same that you would with any other patient. We do want to be notified with the advanced heart failure team before we do any reversal to their anticoagulation. If we reverse, we put the patient at more risk for developing clot. Another complication, thromboembolic complications, or those clots. The most common place that people develop those are inside the heart pump. Now, because the heart pump is in the arterial system, occasionally those clots can be thrown. They can be thrown to the head and we'll have an embolic stroke. They can be thrown elsewhere. We'll have pulmonary embolus. I've seen ischemic leg due to a thrown thrombus. Those patients you're going to treat the same that you would any other way. We aren't going to administer thrombolytics, and typically they don't qualify because they're already anticoagulated. Infection is another complication that can go along with VAD therapy. The most common place that we see it is at the driveline exit site, but at Abbott, our driveline infection rate is somewhere between about 5 and 6% of patients that have infection. So if you're picking somebody up and you think that they are infected, we actually ask that you don't open the VAD dressing site. We want to do that in a clean environment. Ideally, people are wearing masks and they know how to change the dressing and put that right back on when they are through looking and evaluating that. But infection can happen elsewhere. So patients may have problems with bacteremia, and you may be picking them up because they have a sepsis picture going on. Those people will present hypotensive, and you're going to treat them the same that you would with anybody else. Right-sided heart failure is another complication that can go along with these devices. The pump is most commonly placed on the left side of the heart, but we still need the right side of the heart to function and pump appropriately. So in right heart failure, patients tend to develop heart failure symptoms again. They're backing up with fluid. We want to limit if people look like they're having right-sided heart failure fluid. but we need to have enough fluid to make the pump work. So 500 cc's of fluid, even if somebody is in right heart failure, isn't going to be the end of the world. You're going to want to bring them in and we'll treat them inpatient. Pump malfunction is another complication. Though it's a very rare complication, the VAD will be alarming. Sometimes the VAD is alarming and it's still running. Sometimes the VAD is alarming because it is off. The easiest place to assess that in the HeartMate system is going to be this green circle. If the green circle is on, the pump is running. If we create an alarm situation where the patient is having low flow, what's going to happen is the VAD will be audibly alarming, but the green light is still going to be on. The low flow indicator on this device is going to be this heart. It's going to show up red, and on the screen it's going to say low flow, call hospital contact. If that's the case, we want you to call the VAD coordinator and look for some advice. If the low flow resolves with fluid or any other intervention, the alarm will just stop automatically. The other device system that we have, the hardware system, the equipment looks a little bit different. So we have a controller. The batteries are a little bit smaller in this system, but the emergency alarm in this one actually sounds more like a British police car. It will again alarm red, but it will sound again. If the alarm resolves with intervention, it will stop on its own. If you have a patient whose pump is completely off, you're going to want to transport them as soon as possible, but go by if the patient is awake and talking to you, or if they are non-responsive, then we are going to want to treat the way that we would anybody else. So in an emergency situation, Abbott has a VAD coordinator on call 24/7. We can be reached at 612-916-6638. And we can offer advice or how to fix equipment or alarm issues. When you're picking somebody up in an emergency situation, you want to make sure that you're assessing perfusion. Now, the pulse may or may not be palpable, so what other signs can we look at, or indicators of perfusion? We're going to look at mental status, we're going to look at breathing, we're going to intervene if you need to, look at skin color and temperature, blood pressure if you're able to get it, but remember most VAD patients are going to have this narrow pulse pressure, and we're looking solely at the mean pressure. We don't necessarily care about that systolic pressure being low. And if you're intubating a patient, you can always look at end-tidal CO2. Anything less than 20, you're going to resuscitate the same that you would anybody else. The way that we're going to treat inadequate perfusion, we're actually going to do it the same that we would anybody else. VAD patients can receive chest compressions. In the past, we have suggested that people do not get chest compressions, but recently a retrospective look was done at a number of patients that did receive chest compressions, and what we found is none of the equipment, internal or external, was damaged by chest compressions. The patient didn't always survive, but the equipment wasn't damaged. So we do recommend that in an arrest state, you do provide chest compressions to the patient. It is okay to use the Lucas device. Ideally, we will wait 6 weeks from a sternotomy before we're doing Lucas, but if a patient needs chest compressions and they need to be transported, we know that it's a much better system to use the Lucas device. Patients are typically in the hospital 2 to 3 weeks after receiving an LVAD, so it is a potential that you would come across somebody that would need assistance or resuscitation before that 6-week mark. Again, if they're needing to be transported and you can provide compressions, you can use the Lucas. They're coming into us. We will evaluate and assess what the sternum is doing at that time if the patient does survive. With the electricity, you can use an AED or an external defibrillator, the same that you would with anybody else. The vast majority of our patients do have internal defibrillators, and we're going to let those cycle the way that they normally would. If you're using an external, we want to make sure that we're placing patches anterior or posterior. That seems to work better than placing over the left chest where the pump is at. Avoid that if at all possible. Another consideration with an AED or an external defibrillator is that it does not matter if the patient is on batteries or plugged into wall power. It won't damage the system, so go ahead and deliver that energy the same that you would with anybody else. Rhythm disturbance with perfusion. It's very important with a VAD patient to assess the stability of your patient despite what the EKG looks like. So we know that LVAD patients tend to tolerate ventricular arrhythmias very well. So people may be in a tachyarrhythmia, anywhere between 150 and 250 I've seen, and they are awake and talking to you with an adequate mean pressure. In this case, we aren't going to want to externally defibrillate the patient. If their internal device tries to shock them out of it, that's one thing. But if they're awake and talking, we want to try to transport them into us as soon as we can so that we can sedate and use their internal device to get them out of that rhythm. VAD patients are known to tolerate these types of rhythms for a long period of time, hours. It's been reported that we've had people in VT for a few days, and they're doing fine. We want to look to treat the underlying cause of the emergency. Most likely, it's not going to be the VAD that's the cause of whatever you're picking your patient up for. So it may not be that if you're resuscitating, chest compressions are going to fix. VADs need volume. They have to have enough volume to pump throughout the system. They're a set speed and they will continuously run. So if the VAD is alarming low flow, it's always important to give a little bit of fluid back. Start with 500 to 1,000 cc's. You can reach out and ask for advice from the VAD coordinator if you feel that's necessary as you're treating your patient. But look to the common complications. Have those in the back of your head. Is your patient bleeding? Do they have a clot somewhere? Have they had a stroke? Are they septic? Is their VAD malfunctioning and alarming? If the VAD's alarming, you're going to treat that first, and then we're going to treat everything else. Where the driveline exit site comes out, you can see in the center picture, that's what a normal healed driveline looks like, though we always want a dressing to be over it. So there may be a gauze dressing, there may be a clear looking like a central line or a PICC dressing over it. Either is fine. We want to be extremely careful because this is the power and the data that are feeding the pump. So you want to make sure that if you're removing clothing that you're not cutting through this line and that you're keeping this equipment very close to the patient's body. The equipment can look different. The heart-made equipment, typically patients have controllers in a leather pouch, wearing it on their waistband. Batteries can be in a battery holster on their sides. Some people like to wear things in a fishing vest. A new trend that I have seen is shirts made with for conceal and carry, and they have pockets, and they slip the batteries in those with a shirt over the top. It's hard sometimes to tell that patients have a VAD until you kind of expose the equipment underneath. Some people wear it in a belt or a fanny pack on their waist. So just be aware that if patients look like they're carrying some sort of equipment, to assess it and see what they've got. All VAD patients have an emergency bag. We issue a bag that looks like this. It looks like a black camera case. It will have an ID tag on it alerting you to medical equipment. Some people like to carry their equipment in a backpack. So if you're meeting a patient that has an LVAD, it's important to ask them, where is their emergency equipment? This needs to transport with them. This is a very important piece. Inside this bag should be enough equipment to run the entire system, an extra controller, extra batteries, and emergency contacts. So inside the bag, in the top cover, you'll find a little mesh pocket. Inside this is going to be the emergency contact information. Whether the patient was implanted in a line of facility or a different facility, this is a universal place to look for the emergency contact information for that patient. Some patients will also wear medical alert, but looking in that emergency bag is always a great place to go. So if you pick up a VAD patient, ideally you're going to stabilize them. If you're able to bring them back to their admitting center, that's the best because we know the patient very well and we can troubleshoot and treat quickly. However, if your patient is unstable, it is fine to go to the closest place, local ED to have them be stabilized and then transported to us. Make sure you're bringing that emergency bag. Make sure as you're securing the equipment to the controller or to the stretcher, you want to make sure that you're not having equipment falling or dangling off. Ideally, placing it on the patient's abdomen or kind of in their between their legs will keep it safe without stretching the equipment and causing any damage to it. This equipment has been rated fine for transport via ground or air. When we look at the three most common scenarios that I'm seeing patients call EMS for, we'll just talk through the three of them. So in the first scenario, EMS is activated, patient is unconscious, and the VAD is not alarming. So what can you do in this situation? There is a VAD coordinator on call if you want to call and reach out to us. But as you assess the patient, you're going to not find a pulse, decreased LOC, really minimal effort with breathing. They're warm, they're pink, and they have good cap refill, suggesting that they have some perfusion, but you're unable to get a blood pressure. So what do you do for this patient? We don't necessarily care that we don't have a pulse, that's expected. Breathing, not going very well, so we're going to assist their breathing, intubate if you can, and monitor end-tidal CO2, that'll help with some perfusion. Again, not uncommon to see blood pressure, or not have a blood pressure. You're going to try to stabilize this patient and get him to the closest facility that you can. In this case, a CT scan reveals that this patient had a hemorrhagic stroke. We're going to admit and treat as need be. Another scenario that can happen frequently is that the patient calls EMS. They're not feeling well. They're weak, they're dizzy, things aren't going great. Their VAD might be alarming, low flow, but they're awake and talking to you. Again, VAD coordinators on call, you can reach out to us for extra advice if you're looking for that. Not going to find a pulse in this patient, but his LOC is adequate. He's awake and talking to you. He's breathing all right. He's kind of cool. He's not perfusing the greatest, but again, he's awake and talking, so we have some perfusion. Not able to get a blood pressure. In this case, what we want to do is we want to treat that alarming VAD. So reaching out to the VAD coordinator, we're going to direct you to give fluids at that point because we want to try to get a little bit of volume back in this patient to see is that going to fix that low flow alarm. Okay, not able to get a blood pressure. When you transport that patient in, labs are going to reveal a low hemoglobin. Patient is GI bleeding, so we're going to admit and treat as need be. Worst case scenario, it doesn't happen very often, but a patient is found unconscious, their VAD is alarming, low flow. How are you going to treat this patient? When we look at assessing their perfusion, they don't have a pulse, decreased LOC, they're really not breathing, they're kind of bluish in color, you're not getting a blood pressure. This patient needs to be resuscitated, and you're going to resuscitate a VAD patient the same that you would anybody else. Go ahead and follow your ACLS guidelines, intubate them if you're able, transport them into us. We do occasionally put LVAD patients on ECMO to try to sort out what is the underlying cause of their arrest. So again, our emergency number at Abbott Northwestern is 612-916-6638. We are available 24/7 to assist in patient emergencies, to offer advice, to help recommend or get patients admitted to the hospital. At Abbott Northwestern, we implant about 50 VADs a year. The current average survival for patients is about 80 to 85% at the 2-year mark. As of fall 2018, we have a patient that's 7.5 years and running on their device. So in summary today, when you're taking care of an LVAD patient, you want to make sure that you're very careful with that external equipment. Remember that they may not have a pulse, and so we want to look at other indicators of perfusion. If you have a patient that's in a resuscitation state, it is okay to do chest compressions. Ideally, we're waiting 6 weeks to use the Lucas device. However, if you need to transport a patient, it is safer to put them on Lucas and transport, even if it's before that 6-week mark. If you're using an AED or an external defibrillator, it is okay to shock a patient while they're attached to batteries or to wall power. It won't cause any damage to the system. Thank you for your time today. If you have any questions, please feel free to reach out to the VAD coordinators at Abbott Northwestern Hospital.